Hi friends, welcome to Young Ophthalmologist channel. In this film, this is a one-eyed patient in whom while doing rexes, you can see some folds are coming. So in this film, we will see how we manage this case. So while doing the rexes, as we notice these folds on the capsule, we thought that there must be some zonular weakness. So accordingly, when we started the case, it seems to be a normal case with a dilatation of 4 to 5 of pupil, and as usual I put cornea visco. Then we made an entry of 2.8 on posterior limbal side. It's a 3 planar incision which gives good closure of the wound. Air was injected and blue dye was injected to stain the capsule. Till time everything seems to be normal. As it was a one-eyed patient, so I was a little bit cautious on each and every step. Visco was injected. Visco dilatation happened. Now, as we started the rexes, you can see I am using a 26 gauge capsulotome. I gave a nick and started the capsular axis in anti-clockwise direction. Now some folds are visible. It shows that there is zonular weakness in this quadrant. The rexis was completed with the centripetal force and it was pulled inside. It was a little bit difficult to pull it inside. It was more elastic on pulling. The rexis size is almost 5 In soft cataract and in hard cataract both, your rexis should be in bigger in size. It makes the things easy while doing the phaco. A paracentesis side port incision was given. Now it's time to do hydro. We'll do the hydro and release the pressure in the anterior chamber and also express the anterior capsular part. Hydro was done in all the quadrant. The nucleus is pressed in between to release any pressure behind the nucleus to avoid any posterior capsular rent. Now we put the visco to form the chamber and nucleus rotation was done as I do in all my cases, so that all the corticocapsular adhesions got released and it will be easy to rotate the nucleus during phaco also. It seems to be a little bit sticky, but the nucleus is rotating properly. Now it's time to do phaco. We are starting with phaco 1. The parameters are energy is 60, vacuum is 40 mmHg and flow rate is 24 ml per hour minute. A central trench was created for stop and chop. I prefer to do stop and chop in both hard and softer cataracts. It is very predictable. Only you have to take care about the depth you have to go. The width of the tunnel should be 1.5 times the phaco tip and the depth should be at least 90% so that you will be able to see the glow. I normally do one side only tunnel. I don't rotate. With experience you can also do this. Don't need to rotate. Now as you break the nucleus, you have to go the deepest part of your tunnel. You can see that the nucleus is divided into two. As I am rotating the nucleus, it's not getting rotated easily. Now we are in phaco 2 with vacuum 380, flow rate 40 and power 60. We got a break, but it was not able to come out. The nucleus seems to be sticky there. As the patient is one-eyed, I am not in hurry. Slowly, I'm trying to hold the nucleus, but it's going back. So most important thing here is, as we are expecting zonular weakness, so whenever you are coming out, don't let the chamber collapse. So I am putting some visco from the side to maintain the chamber. At this time, irrigation is stopped and you can remove out the phaco once the chamber is formed. Now I am trying to prolapse the soft nucleus into the anterior chamber, as we have got the broke lens by making the tunnel. Some more visco is inserted into the eye. Again, because the nucleus is sticky, it's getting difficult to prolapse it. I am trying to go towards the equator and trying to prolapse it into the anterior chamber, but it's coming into bits. Don't be in hurry in these one-eyed patient. These sticky and soft cataracts are sometimes difficult, more difficult than the hard cataract. So here we got the nuclear equator and able to prolapse the bigger piece of the broken nucleus. We have to use good amount of visco when we are doing this to avoid any endothelial damage. Now we are in phaco 2, entering into the eye. In my left hand there is a soft dialer, not having very sharp edge. Slowly, you should not give lot of energy here. Slowly in the anterior chamber we are eating this soft nucleus. 50% of the nucleus is eaten by the phaco. As I am trying to catch the remaining part, because of the stickiness, it's not coming out easily. So again, instead of trying too much, I will prolapse it into the anterior chamber, and the pupil is also getting smaller in size. Again here, you have to remember that whenever you are removing phaco, always push visco and form the chamber. Don't forget this thing. Otherwise, if zonules are weak, we can have vitreous prolapse. Now with the help of a soft dialer, I am trying to rotate the remaining nucleus. Again, from equator we are trying to bring it to the anterior chamber. The remaining part of the nucleus came out into the anterior chamber. Now we put lot of visco to coat the endothelium and below the nucleus also. Now it's time to eat this nucleus. We are using phaco 2. The parameters are same. The vacuum is 350, power is 50, flow rate is 40. Be careful, as the pupil is also getting small. We are trying to take out the epinucleus. Now it's phaco 3, where the power is 25, flow rate is 24, and vacuum is 250. The epinucleus is removed. There is a hidden part of cortex. Slowly we are taking that out also with phaco 3. It's safe to come to phaco 3 while removing the epinucleus, and don't try to do it with phaco 2, because that sometimes causes rent. Again here, cortex wash is done, but still we are pushing visco. Every time we have to take care of this thing. Now I am using coaxial IA to remove the remaining cortex. The pupil is small in size. Now it's almost 4.5 mm. The cortical wash is done. In these cases, we have to take care that sometime the cortex get hidden by the iris when the what's smaller. So if you want, you can pull the iris and can check behind the rexus margin also. As you saw, one epinuclear piece stuck into the coaxial, so I removed it with the dialer. Again, the visco is injected and chamber was formed. Now the case is done almost. I am putting a hydrophobic care group acryol lens into the eye. The lens is successfully placed and dialed under the back. Now it's time to wash the remaining visco.